Hello, I'm Eleni Efstathiou, and we're here in very good company in San Francisco, quite early in the year, so Happy New Year. 7th of January, GU ASCO never happened before. Has it? I don't think so. But anyway, we're enjoying a good weather, which was not anticipated, but also a great first day of ASCO discussing prostate cancer. What else? With me, Axel Merseburger from Germany, a urologist. Nick James, becoming extremely famous this year, in a clinical oncologist, which means that he practices both medical oncology and radiation oncologist. Yeah. And of course, the famous Karim Fizazi from France. So gentlemen, you're going to enlighten us today of what's going on in prostate cancer for 2016. Axel, I think you should pick the most difficult part, which is local disease. Not a lot was said today. What was your take-home message for your practice moving forward?
Well, Eleni, thank you for introduction, and thank you for having us here. And my experience from the first day, it was very exciting, a lot of data, and my take-home message from local therapy was the presentation by Professor Shipley, focusing on the topic of salvage therapy. There we have the discussion on when to start since years. But now a novel aspect came into play, the use of ADT, and I thought it was very interesting. He presented a trial on 24 months, 150 milligrams bicalutamide in combination with salvage therapy, radiation therapy, compared to just the standard.
Just radiotherapy alone.
Just radiotherapy alone. And what is groundbreaking for, I think, clinical practice was the news that you had an overall survival benefit from 78 to 82 months. Also a reduction of prostate cancer death rate in this situation, and also a reduction of occurrence of metastatic disease. So I thought this is something I would take home from San Francisco to Germany to communicate to my colleagues, and would like to hear your opinion from interdisciplinary view if we should use this as standard of therapy. And I think it might be advised from looking at the side effects.
Are you going to?
I will.
You will, as of tomorrow?
Yes, as of tomorrow, yes.
Nick?
Yeah, it's been a very hot topic in the UK because in most settings where we use radiotherapy, we use hormone therapy as well, and androgen deprivation therapy as opposed to anti-androgen therapy, which of course is what bicalutamide is. Yes. And when UK practice was surveyed, and Chris Parker's the guy that's done a lot of the running on this in the UK, there was a big range of, some people did not give hormone therapy. So there's a big trial recruited out in the UK now called Radicals, which is randomising no hormone therapy, 6 months androgen deprivation, and 24 months. That's finished recruitment. It's going to report at some point in the next year or so. But the other thing that was very interesting to me was all the data about the node positivity, because one of the debates we have in the clinic is around, do we there's 1 or 2 positive nodes out, only 6 being taken out by the surgeon because they thought it was low-risk disease, but now it's node positive. Should we irradiate the pelvic nodes?
Yes.
Adds the toxicity. And I think that is another unresolved question.
This is also something what affects us urologists, since Alberto Briganti was covering this in his talk today. It was very, very nice. And he concluded that either when you do it, you should do it extended. Even when you do it with a robot or open or laparoscopic. And I think I will go along with that to take out as many lymph nodes as possible to get staging results and possible cure.
From the radiation oncology, because we have this debate every week in our MDT, the more nodes that you guys take out, the more morbidity there is from adding radiotherapy. So if you just do a sampling, we can safely give radiotherapy. You don't end up with legs like elephants' legs. If you take out loads of nodes and then we irradiate because they're all positive, then we're in big trouble with the radiotherapy. So we flick-flack back and forth. And so our surgeons are currently doing a sort of sampling type level of procedure, because then we know we can safely add radiotherapy on.
Just in the obturatora fossa and not extendedly.
I have to say my anatomical knowledge of what the surgeons do is slightly
because I thought
hazy.
It would help you if you get the regions and know that there are positive lymph node in the external iliac vessels. Would it help you? From radiation-wise, where you have to...
So the field that we would normally do, if we would include the external iliacs down to the inguinal ligament, and we would go our standard pelvic field goes up to the aortic bifurcation. Because with IMRT you can get the dose in, but obviously
That's
if you
interesting.
take So I think the way that we'll resolve this, so I think is around things like PET imaging. I think we're very excited about the PSMA,
Like
PET
PSMA
data.
PET,
We've
But I
been
think
doing more
now
and more
you're
of it.
becoming all too enthusiastic. So I'll bring you back to today.
Yeah.
What about hypofractionation, since we're still in radiation?
So there's a lot of slightly arcane old data around the impact of fraction size on treating prostate cancer, and the models predict that a bigger fraction size and fewer fractions should have a better therapeutic effect than the current way we do it, which is a large number of small fractions. So there were 2 trials presented today, an RTOG one and a UK one, looking at different hypofractionation. So the interesting thing about the hypofractionation trials was that they were non-inferiority trials. So they showed essentially equal toxicity with a bigger dose per fraction, which should increase the toxicity on normal tissues. So that you give a slightly lower dose to compensate for that. So it looked as if the models predicted correctly that you could hypofractionate, reduce the total dose a bit, get the same effect on the cancer, but with a shorter treatment. And certainly in the UK, obviously the CHHiP trial was a UK trial, pretty much across the board people have switched practice. So we got off the plane from Vienna, which is when David Durnley first presented the data, and as a department we changed our practice that week. Across the board.
So we're going to tell our patients that you're only going to take 20 days to finish.
20 fractions instead of 37 was the change that we made. So that's a big change for the big resource implications.
Well, for the future, for all these patients who are waiting in some public services to get in line to get radiation, for the cost of some people who come from a long distance, makes a big difference.
It does, and I think the thing that was striking about both of those trials is that they very impeccably collected toxicity data, both acute and late, so that the data were very credible.
But today you also presented some data on an arm that I thought was dropped.
Yes.
And you surprised us.
Yes, we surprised ourselves, I have to say.
Okay, that's actually
so we set up the STAMPEDE trial to look at a number of agents, and we picked some agents which were either in the clinic or heading there, zoledronic acid and docetaxel, and then we picked celecoxib because there was a lot of data, both in vitro and epidemiological, suggesting it had anti-prostate cancer effects. So we were looking at to repurpose an existing drug, if you like, and we're still trying to figure out what the data mean, but essentially there appears to be a different effect of celecoxib in M0 and M1, so the effect was all in the M1. And then the second thing was that although we presented the zoledronic acid data as being negative, there is evidence of a weak effect. So what we think is you had a weak effect from 2 different drugs and you end up with a less weak effect. And so we came up with a survival advantage for celecoxib combined with zoledronic acid.
Kind of trying to defend it, but it was a positive result.
It was a pre-planned analysis.
Let me get an independent reviewer here. Karim, what do you think of that data?
Really difficult to analyze it. I mean, that as Nick just said, that was surprising. PFS was not met. Overall survival seems to be met, but it's met only in combination with zoledronic acid and only for the M1 subgroup of patients. So we cannot exclude that this is just by chance, of course, because when you do subgroup analysis and everything, and when you have multiple arms, you can have just one positive by chance, but it can also be something true, and it's obviously impossible to know where we currently stand. I'm not sure that is going to change all the practice for tomorrow. Those 2 drugs are not approved in this setting, and again, because we cannot make sure it's not just by chance, it's probably not change how we treat these patients. But perhaps more generally, it reminds us that we should also think again about integrating in clinical trials drugs that are not necessarily only anti-cancer drugs. And I'm thinking, for example, about the role of statins, about metformin, about aspirin. There are plans in Canada to do a randomized trial, a very large randomized trial in localized disease, testing some of these drugs. We also have planned to do that in Europe, perhaps within STAMPEDE, perhaps within Peace Consortium, etc. And we might find some good news. With these old drugs, quite cheap, quite non-toxic. We'll need to know that.
Well, interesting.
I was going to say, because we're adding, as you know, metformin into the STAMPEDE trial as a new arm. That'll go live at some point this year.
But as you were presenting, all I could remember was all these patients who've come in a clinic with celecoxib on them, and I've stopped it because of the black box warning.
Yeah.
And now I'm like, I need to call them.
Well,
put it back on.
well, our DMC obviously been monitoring that very carefully because this was obviously a concern. This was already known when we started the trial. So we excluded patients with a cardiovascular history, and we didn't see any excessive cardiovascular problems in patients that we put in the trial. Now, obviously, that doesn't mean it's safe for all patients, but it's certainly safe for the patients we put in the trial. And this is pretty mature follow-up now on 1,200 patients, so it's pretty robust data.
So today, Karim, you presented data on a different type of design of a trial. Would you like to share some of this information?
Sure. That's really for patients receiving the Taxol for CRPC, classical the Taxol therapy for advanced prostate cancer, who are benefiting from the Taxol. And that's typically a patient who has received, say, 6 to 10 cycles. When you decide to stop the Taxol, and your patient is asking you, well, what's next? And typically I'm telling the patients, well, you go on vacation, and I'll see you again in 2 or 3 months from now. And after that, when they're coming back to me, they're progressing. So we probably need drugs to postpone progression when we're stopping chemotherapy, as we all do probably in breast cancer and other cancers, or lung cancers, etc. So it's a switch maintenance concept that I wanted to test for prostate cancer. We did that with tasquinimod, which is an experimental drug, and which was an experimental drug when we designed the trial, and that was a randomized trial for, again, these patients benefiting on docetaxel and stopping docetaxel, comparing tasquinimod versus placebo. The primary endpoint was radiographic progression-free survival, and it's a positive trial. We were looking at a hazard ratio of 0.6, and this is exactly what we saw. Now, having said that, this drug is probably not going to be further developed because another pivotal phase 3 trial also reported positive PFS but negative overall survival. So there's probably not going to be a big future for this compound. But I think the concept is interesting, and we should think about maybe new drugs to be tested post-Taxol, either in CRPC or in hormone-sensitive disease. And this is probably the future for these patients.
Immediately as you're talking, I think a lot of us are thinking, oh wow, celecoxib could go into your design as well. But all of these patients are on bone-modifying agents anyway when they're CRPC.
Right.
So very exciting. What did you think about the circulating tumor cell story that Howard Scheer presented today?
Right. So basically what we know about CTCs is that, number one, that's a quite strong prognostic factor, but it's not truly helpful. I mean, for CRPC, you know that if a patient has a high CTC level, it's going to do bad as compared to patients with a low one, but it is as it is.
Do you use it in your clinic?
No, because it's expensive. I mean, and for basically no true information. Now, more interesting is that in the context of clinical trials, it's a nice way probably to measure response to a given drug, at least to some drugs. But still, it's an expensive way to measure response compared to PSA response, clinical assessment, and radiographic assessment. But it is something. Now, perhaps more interestingly is when you're trying to look at molecular analysis on CTCs, and this is really an open field, and this is something we're trying to do. Say, if we can look at ARV7, if you can, etc., to better decide which drug should be used. And today, Howard looked at basically the shape of the cells with different patterns, and it could show that there is obviously heterogeneity, which was something we were suspecting already, and that depending on the subgroup of patients, based on the CTC shape, if you will, your patient might or might not benefit from abiraterone and enzalutamide, while the taxane seems to be active in the various subgroups. So we're learning more and more. It's not going to change our practice tomorrow, for sure, but we're making progresses with regards to CTCs, I believe.
This data reminded me very much of Bova's paper. In a way, the Bova this year, and I'm going to talk about that tomorrow, went and looked at all the heterogeneity of the clones of metastases, and that subclonal metastases. And it will be nice to see that next generation of actually looking at those tumor samples and the heterogeneity in those circulating tumor cells.
Okay.
So overall, what would you say was today's take-home message for us in the field of prostate cancer?
Well, I guess it has to come back to overall survival. And we heard today a trial that showed overall survival. This is the one Axel summarized. It's a bicalutamide trial on top of radiation for patients with a rising PSA post-local treatment. And overall survival was met in this trial. So I guess this is very important. And on top of that, we need to remember that we need to be patient with prostate cancer. This trial was actually designed in the mid-90s, which is 20 years ago, and it took really 20 years before we had overall survival data to change our practice for tomorrow, as we all said. And this is very important. And again, this is an academic trial that was not an industry-sponsored trial, because we need the time. So that is also important to remember.
Thank you very much for your comments, gentlemen. Thank you very much for attending this session.